Breast cancer, or breast carcinoma, is an uncontrolled growth of epithelial cells within the breast. It's the most common cancer in women, but can rarely affect men as well. Now, estrogen and progesterone stimulate breast cells to grow and divide, and exposure to them over long periods of time increases the risk of breast cancer. More menstrual cycles over a lifetime means a higher cumulative exposure to these hormones. That's why factors that increase the number of menstrual cycles increases the risk of breast cancer. That includes things like early menarche, or a first menstrual bleeding before 11 years of age, and late menopause, after 54 years of age. On the flip side, some factors that are associated with fewer lifetime menstrual cycles, like pregnancy and a longer time breastfeeding, decrease the risk of breast cancer. Similarly, hormone replacement therapy used to treat menopause symptoms also increases that risk. Another risk factor is exposure to ionizing radiation, like from chest x-rays and CT scans or previous radiation therapy for other cancers located in the chest. Breast cancer has been linked to mutations in tumor suppressor genes, like BRCA1, BRCA2, and TP53, which normally prevent uncontrolled cell division. Some breast cancers have mutations in the ERBB2 gene, which causes an increase in human epidermal growth factor receptor 2, or HER2, which promotes cell division. Finally, some breast cancer cells have estrogen or ER receptors and progesterone or PR receptors, which allow them to divide faster in the presence of these hormones. Breast cancer is the second leading cause of cancer deaths in women after lung cancer, and this is largely due to the fact that breast cancers often don't cause pain or discomfort until they've metastasized. Now, breast self-examination isn't recommended for screening purposes, because it has not been shown an overall benefit. In fact, it's led to a higher rate of breast biopsies that shows benign disease, and leads to some women doing it instead of mammography. Nevertheless, some women who feel safer doing a breast self-exam should learn the proper technique. The best time for breast self-exam is during the week after menstruation ends, or any time of the month for postmenopausal women. The first thing to do is stand in front of a mirror and check the breast for any changes in skin color or texture, dents, and the appearance of the nipples, as well as signs of breast asymmetry. Next, the woman should lie down and use one hand to examine the breast on the opposite side, starting in the upper breast near the armpit and going up and down, and slowly moving across the breast. Using the 3 middle fingers, she should make small circles to feel into the breast. Once one side is done, she should change hands and feel the other breast. In breast cancer, there's often a single, hard, immovable lump with irregular borders. Other characteristic signs of breast cancer include skin retraction and ulceration, or an inverted nipple. Now, in the general population, the recommendation is mammography screening for women over age 40. For women between 40 to 49 years, the screening frequency is variable, with some recommending annual screening to identify aggressive breast cancers that can occur in this age group. Women aged 50 to 74 should get mammographic screening once every 2 years, and women older than 75 years should continue screening only if their life expectancy is over 10 years. If mammographic screening identifies an abnormality, then the next step is supplemental mammographic views, or an ultrasound. Now, for high-risk women, meaning those who have a BRCA gene mutation or other susceptibility genes, or women with a history of chest radiation, should have an annual screening breast MRI. If they can't have an MRI, then a screening ultrasound is recommended. These women still get annual mammography, so they effectively get one screening test every 6 months. Once a cancer-causing mutation does happen, the affected cell, which is most commonly an epithelial cell that lines the ducts or the lobules, begins to grow and replicate out of control, forming a tumor. This tumor, also called in situ carcinoma, is initially localized within the basement membrane of the alveoli, and can be of 2 types. The most common type is ductal carcinoma, which starts as ductal carcinoma in situ, or DCIS. And that's where tumor cells grow from the walls of the ducts into the lumen. DCIS often has calcifications, which can be spotted on mammography. If left untreated, DCIS over time can often cross the basement membrane to become invasive ductal carcinoma. Then there's lobular carcinoma, which again starts as lobular carcinoma in situ, or LCIS. And that's where clusters of tumor cells grow within the lobules, without invading the ducts, causing the affected alveoli to enlarge. Unlike DCIS though, LCIS rarely crosses the basement membrane to form invasive lobular carcinoma. Also, unlike DCIS, LCIS rarely has calcifications, so it's not recognizable by mammography, but it is recognized with ultrasound. A rare and aggressive form of breast cancer is inflammatory breast cancer, which happens when malignant cells block the lymph nodes in the skin of the breast. Inflammatory breast cancer is different from other forms of breast cancer because it usually doesn't cause a lump or mass, so it's particularly tricky to diagnose. Initial symptoms include itching, pain, swelling, nipple inversion, warmth and redness throughout the breast, and peau d'orange, which is when the skin has the appearance and dimpled texture of an orange peel due to cutaneous lymphatic edema. The signs of more advanced disease include axillary lymphadenopathy, as well as Paget's disease of the breast, which causes skin changes like redness, discoloration, and mild flaking of the nipple skin, resembling eczema. As Paget's disease of the breast advances, symptoms include tingling, itching, increased sensitivity, burning, pain, and even bloody discharge from the nipple. Any of these symptoms should trigger mammography and breast ultrasound, and the preferred modality depends on the breast consistency, which is largely determined by a woman's age. In women over 30, mammography is the preferred first imaging technique. Mammography shows tumors that have calcifications, and key findings are spiculated soft tissue masses and microcalcifications. Unfortunately, there are some tumors that don't have calcifications, called mammographically occult disease. And there are also some aggressive cancers that develop quickly between mammograms called interval cancers. In women under 30, a breast ultrasound is the preferred first imaging technique. The ultrasound helps differentiate between solid and cystic breast masses. If the ultrasound is indeterminate, mammography is often performed, although it's less effective in young women. Now, regardless of imaging results, all palpable breast lumps must get their cytology and histology done to confirm the diagnosis. In addition, lymph node involvement must always be assessed with lymph node biopsy. Cytology is done through fine needle aspiration, or FNA, where fluid from the lump and suspicious lymph nodes is taken under ultrasound or mammographic guidance. The visual appearance of individual cells helps identify their proliferation rate and malignancy potential. Histology is done with a core biopsy, where a needle is used to obtain a sample from the lump. Generally, a percutaneous palpation-guided or imaging-guided biopsy is done. If that's not feasible, then a surgical biopsy can be done. Histologic testing for ER and PR expression, as well as for overexpression of human epidermal growth factor 2 or HER2 receptors is done. Based on that, breast cancers are divided into three major types: HER2 negative and ER and PR positive carcinoma, which is the most common, HER2 positive and ER and PR positive or negative carcinoma, and HER2 negative and ER and PR negative carcinoma, called triple negative breast cancer. Additionally, an MRI can be done, which is particularly helpful in females with breast prosthesis. Nearly all invasive breast cancers enhance on gadolinium contrast enhanced MRI, even ones that are not evident on physical examination, mammogram, or ultrasound. MRI findings include irregular or spiculated margins, rim enhancement, heterogeneous internal enhancement, and enhancing internal septa. The most common sites of breast cancer metastasis are the bone, lungs, and liver. Individuals with bone pain or an elevated alkaline phosphatase should get a bone scan. If the bone scan is negative, and if there's a persistent concern, then an MRI of the concerning region should be done. For individuals with respiratory symptoms, a chest X-ray or chest CT can be done to look for lung metastases. For individuals with elevated transaminases, or an elevated alkaline phosphatase, or abdominal pain, a CT scan of the abdomen and pelvis should be done. Finally, in individuals with numerous symptoms, a whole-body PET CT should be done. After the workup is complete, breast cancer is staged using the TNM system. T indicates the size of the tumor and whether or not it has grown into nearby areas, for example the chest wall muscles. N describes the degree to which the cancer has spread to nearby lymph nodes, particularly the axillary lymph nodes. The internal mammary or supraclavicular nodes might also be involved at the initial presentation, but they rarely occur in the absence of axillary node involvement. And finally, M indicates the presence of distant metastases. Each of these categories is ranked from 0 to 4, with 4 being the most severe. The TNM system classification determines the stage of the breast cancer, where the stage is between 0 to 4. Stage 0 is a precancerous or an in situ disease, meaning that the tumor has not invaded beyond the basement membrane. Stages 1, 2, and 3 are non-metastatic breast cancer. Early stage breast cancer includes individuals with stage 1, 2A, or stage 2B disease that's T2N1. Locally advanced breast cancer includes stage 2B disease that's T3N0, as well as stage 3 disease. Finally, stage 4 is metastatic breast cancer. Treatment for breast cancer is based on the type, stage, and pattern of receptors that are expressed. Surgery is the mainstay of treatment whenever possible, and is followed by other treatments like radiation, chemotherapy, endocrine therapy, and targeted therapy towards specific receptors expressed by the tumor cells. Medications used after surgery are called adjuvant therapy, whereas medications used prior to surgery are called neoadjuvant therapy. The surgical approach to the primary tumor depends on the size of the tumor, the size of the breast, and whether the disease is multifocal, meaning it has more than one location. In breast-conserving surgery, only the affected area is removed and adjuvant radiotherapy is given to destroy tumor cells that might have escaped the surgery. In a mastectomy, the whole breast is removed, either with or without adjuvant radiotherapy. Nearby lymph nodes should be removed if the cancer has metastasized to them. If the preoperative lymph node biopsy is positive, an axillary node dissection should be performed. On the other hand, if the lymph node biopsy is negative, a sentinel lymph node biopsy at the time of surgery should be performed. Individuals with fewer than 3 pathologically involved sentinel nodes might not require an axillary node dissection, while individuals with 3 or more pathologically involved sentinel nodes may undergo an axillary node dissection determined on an individualized basis, taking into account all other tumor risk factors and the individual's performance status and comorbidities. In some cases, adjuvant radiotherapy is given at the time of surgery. Radiotherapy can be given as external beam radiotherapy, where an external source of ionizing radiation is pointed at the particular part affected to send radiation to the tumor or involved lymph nodes from outside the body. Alternatively, brachytherapy is given, which is internal radiotherapy where a sealed radiation source is placed directly inside or next to the area requiring treatment. Following surgery, some individuals might get adjuvant therapy. Indicators of high risk of tumor recurrence include high-grade tumor, large tumor size, larger than 2 centimeters, or pathologically involved lymph nodes. Premenopausal women with ER-positive low-risk breast cancer can be given tamoxifen as adjuvant therapy. Tamoxifen can cause congenital anomalies during pregnancy, so women must be on some form of contraception, and should wait for at least 2 months after discontinuing tamoxifen before attempting pregnancy. Premenopausal women with high-risk breast cancer should get exemestane as adjuvant therapy, as well as surgery or medications like leuprolide or goserelin used to cause ovarian suppression to prevent the ovaries from making estrogen. On the other hand, postmenopausal women with ER-positive breast cancer should get an aromatase inhibitor, like exemestane, anastrozole, and letrozole, as adjuvant therapy. HER2-positive breast cancer gets treated with trastuzumab, alone or in combination with chemotherapy if the tumor is bigger than 1 centimeter. Finally, triple-negative breast cancer that's bigger than 0.5 centimeters generally gets adjuvant chemotherapy after surgery. One of the most common regimens is called AC, and it combines cyclophosphamide with doxorubicin. Sometimes a taxane drug, like docetaxel, is added, and the regimen is then called CAT. Another common treatment is cyclophosphamide, methotrexate, and fluorouracil, and that's called CMF. Most individuals with advanced, inoperable breast cancer should get neoadjuvant systemic therapy, and then have the cancer restaged to see if it's resectable. Most individuals who need neoadjuvant therapy get chemotherapy, since it's associated with higher response rates in a faster time frame than endocrine therapy. For tumors that are HER2 positive, trastuzumab should be added to the chemotherapy regimen. Metastatic breast cancer is unlikely to be cured, so individuals with hormone receptor positive disease are initially treated with targeted therapy, which are generally less toxic than chemotherapy. If individuals have had tumor progression despite being on multiple endocrine medications, then chemotherapy is tried. If the metastatic breast cancer is triple-negative metastatic disease, then chemotherapy is used right away. Some cases might get local treatments, like surgery or radiation, to help prevent or treat symptoms or complications from the cancer, but these treatments are not curative. Alright, as a quick recap. Breast cancer is associated with increased exposure to estrogen, which can be due to risk factors like early menarche, late menopause, and medications containing estrogen. Breast cancer has also been linked to gene mutations like BRCA1 and BRCA2, and TP53. Some breast cancers also have increased expression of the receptors HER2, ER, or PR. Breast cancer generally presents as a hard, immovable, single dominant lump with irregular borders. Other signs are skin retraction and ulceration, an inverted nipple, peau d'orange, bloody discharge from the nipple, and axillary lymphadenopathy. Mammography is first line for imaging women over 30, and ultrasound is first line for women below 30, and both of these can be used to guide biopsy, which can confirm the diagnosis. In some cases, further imaging with an MRI, CT scan, or PET-CT scan might be needed. Screening programs involve mammography and are generally done in women over 50. The first treatment for breast cancer is surgery, which is divided into breast-conserving surgery plus radiation therapy, or mastectomy, either with or without radiation therapy. In addition, nearby structures like lymph nodes might be removed if the cancer has metastasized to them. The most common chemotherapy regimens are AC, CAT, or CMF. Endocrine therapy includes tamoxifen, exemestane, or an aromatase inhibitor for ER-positive breast cancer, while targeted therapy involves trastuzumab for HER2-positive breast cancer. Metastatic cancer cannot be cured, but might be treated with systemic therapy, either endocrine therapy or chemotherapy, as well as local treatments like surgery or radiation to help prevent or treat symptoms in some cases.